we can start?
Yes, please. Shall I start my presentation?
Yes,
or
please. Yeah.
Introduce the participants, sorry, the panelists.
There are about 53 participants that I can see.
So would you like to introduce the panelists or it's done?
Okay, if you want, I can go through the panelist and the speaker as well. Assalamu alaikum, participants. Lovely to see you again on the Apna Merit Forum. Our speaker today is Dr. Mohammad Iqbal. He's a consultant neuro-otologist from UK. We've got a set of panelists. My introduction is I'm Dr. Hina Javed. I'm the moderator, by the way. I'm not one of the panelists. I work as an assistant professor in University of Health Sciences in the Department of Family Medicine. Dr. Abdul Hafiz is here. He's one of the GP primary care physicians based in the UK. Then we've got Dr. Noreen Rafiq. She's an associate professor and faculty, Department of Family Medicine in one of the hospitals in USA. Dr. Mia Ayazul Haq, he's an assistant professor neurology at Lady Reading Hospital in Peshawar. And Dr. Syed Amjad Iqbal, he's a GP in Huddersfield, UK. I will ask the panelists to introduce themselves again at the end, so some of you who have missed this introduction will get to know them again. I think without further ado, I'll ask Dr. Iqbal to start, please. Thank you.
Thank you. First of all, I'm honored by Apna to present this on their platform. Thank you very much. I'm most grateful to the panelists and as well as the audience, viewers, that you have taken time to attend this presentation. This presentation is primarily for primary care physician, but I will discuss few things which might be of interest to you in order to do a differential diagnosis. So let's start with this slideshow. Well, the function of the balance system is to see clearly while one is moving, and you might have seen this example at a train station when your eyes are focused on the person while you are moving or they are moving. It also determines the direction and speed of movement. For example, if an object is coming towards you, and if you want to make some adjustment to the posture or your balance to avoid that object falling on yourself or there are a few other examples as well. Now, you might have seen the gymnastics and others who balance themselves in a very difficult posture. So the balance system is also responsible for identifying the orientation of the body with respect to gravity and make automatic postural adjustments and stability. Without this, we would not be adjusting ourselves and we would be falling again and again. Now, this is the beauty about the balance system, that it keeps us on our feet in normal as well as in difficult position. The balance system can be understand. We can understand the balance system if we understand what are the stimuli which are going towards the brain in order to maintain the posture and stability. So first stimulus is from vestibular system, which is the inner ear. We will discuss this in detail as the topic of my discussion is vestibular dizziness, which means the dizziness which is due to the vestibular causes. The second stimulus or the second trigger or the second efferent, you can say, or the second information you can say is visual. So what we see does help our brain to adjust for the posture and stability. And third is proprioceptive stimuli, which are from the muscles and the ligaments, and they also travel to the brain. Now, when they go towards the brain, they make connection in the brainstem before going towards the cerebrum and cerebellum. We will discuss this in detail as well. So first of all, let me take you to the anatomy of the vestibular system, because you cannot understand the vestibular system unless you know a little bit anatomy about this system. So the inner ear is composed of the hearing part, which is the cochlea, and the vestibular part, which is the otolithic labyrinth, consists of utricle and skew, and 3 semicircular canals. The skew is responsible for sensing up and down movement, whereas utricle is responsible for forward and backward movement and slight head tilt. But the 3 semicircular canals, they sense angular motion. So altogether, they cover all types of movements. You can see over here that we have got anterior canal, posterior canal, and horizontal canal or lateral canal, whatever you want to call this. Then you have got utricle for U and skew for S. Now, the utricle and skew connection is connected to the cochlea as well. So it's not just one system where it is working in isolation. There is a flow of endolymph, the fluid within the labyrinth, to the cochlea as well. And this becomes important in some cases. There is also a duct which runs from the utricle and skew towards the dura mater, and it spreads out. This is called the aqueduct, and this is called the sac. There is a condition which involves aqueduct and the sac and gave rise to vestibular problems. So the pathophysiology of vestibular system can be peripheral, which is utricle, skew, and the semicircular canal, or it can be central, which can be the thalamus, brainstem, thalamus, and the cerebrum, as well as cerebellum. Let me do it on the slideshow. I'm so sorry, why did yes. I think you can see better now. There are 2 nerves, the superior vestibular nerve and inferior vestibular nerve, which takes the stimuli from this balance system. You can see that inferior vestibular nerve is taking the stimulus, taking the information only from the skew and the posterior canal. Now, when this nerve travels in the brainstem near the pons, it integrates into 4 vestibular nuclei, and these are medial, lateral, superior, and inferior. The medial and the superior, they connect heavily in the above nuclei, which are of the oculomotor nuclei, 3rd, 4th, and 6th. This is called oculomotor complex, trochlear, and abducent. So we will understand the function of this connection in a slide, which will come a bit later. But you can see that these nuclei, they are giving the fibers which are running down as lateral spinal tract and medial spinal tract, which are the descending fibers. And these fibers are running up in the medial longitudinal fasciculus towards the oculomotor, trochlear, and abducent nuclei. They also run towards the cerebellum, particularly to the inferior cerebellar peduncle and the flocculonodulus part. And this is important because cerebellum is also coordinating with the balance system and it influences the spinal tract through the vestibular nuclei. So how can we fix to an object when our head is moving? So when the head is moving, it sends the stimulus to the, let's say, lateral semicircular canal over here, because we are moving in the horizontal direction. Then this movement of the head towards the right will allow the eyes to remain focused on the left. You can do this test by asking a person to look in front to you and move the head, but tell them to keep their eyes focused on your nose. And normally they will be able to do this. And this is exactly the same test which we call vestibulo-ocular reflex, that when we turn the head to the right, the eyes will turn to the left. If the head is tilted down, the eyes will move up. If the eyes are tilted up, if the head is tilted up, the eyes will move down. So our eyes remain focused on an object. So you have to tell the person that please look at my nose. If you don't tell, then the eyes will not remain focused. You can see this. The eyes are the head is moving to the in this case left. The eyes will move to the right to remain focused. As I explained to you that from the vestibular nuclei, there are ascending tract, which is going up through medial longitudinal fasciculus to 3, 5, 6, and then descending and also ascending medial fibers, which are going through medial lemniscus to thalamus and to brain. And then there are descending, which are going to the spinal cord, because these are the fibers which will influence the extensor muscle to keep the balance. And then there is vestibulocerebellar fiber, where there are vestibulocerebellar fibers. And one can see all this information on this chart or diagram. I won't go much in detail over here because this presentation is primarily for primary care physicians. These are the fibers which are going towards the brain. The blood supply. For the neurologist, the blood supply becomes very important because one has to differentiate acute dizziness due to stroke or due to peripheral condition. And this becomes more important in the A&E. Now, you can see that there is a basilar vertebral artery, two vertebral artery meeting the basilar artery, and the basilar artery is giving rise to anterior inferior cerebellar artery. So please focus yourself on the anterior inferior cerebellar artery. But after looking at this, you can also see that there is a posterior inferior cerebellar artery, there is a superior cerebellar artery, and there is a posterior cerebellar artery. Now, when we look at the arterial supply of the labyrinth, we can see that the anterior inferior cerebellar artery, starting from the basilar artery, this branch goes toward the cerebellum, and this branch is the labyrinthine artery, which then divides into common cochlear artery, then the acute anterior vestibular artery. Now, most of this anterior vestibular artery is supplying over here. But what I'm trying to emphasize is this, that if there is any problem of the inferior cerebellar artery, it will affect the cochlea and the labyrinth. So you will have problems of hearing loss and tinnitus, as well as the dizziness in obstruction of anterior inferior cerebellar artery. Now you can see over here that this anterior inferior cerebellar artery is supplying the cerebellum, but the cerebellum is being supplied by the posterior inferior and the superior cerebellar, but none is supplying the cochlea or the labyrinth except anterior inferior cerebellar artery. So in the infarct, which involves superior cerebellar artery and posterior inferior cerebellar artery, you will not find the symptoms of hearing loss and tinnitus. And you can see this over here in this chart, posterior inferior cerebellar artery, which is not giving rise to tinnitus or hearing loss. But there are other symptoms which are more important over here, like dysphagia, facial hemianesthesia, facial paralysis, crossed hemisensory loss. So you will be looking at symptoms other than tinnitus and hearing loss. Whereas in the anterior inferior cerebellar artery, you will have symptoms of cochlea, tinnitus, and hearing loss. Sensory lining. So now we have seen the anatomy of the labyrinth as a gross anatomy. Now we look at the fine anatomy, which is called the sensory lining. And we have to look at the otolithic organ first. which is utricle and sacule, you can see that there is a 1 millimeter patch in utricle and sacule, and this is called macula. Whereas in the semicircular canal, we will find a different kind of sensory lining, which I will show you in a second. This lining is placed in a very important way for the function. In sacule, you can see that this lining is vertical. The reason is the sacule is responsible for up and down movement, which are in line with gravity or against the gravity, whereas the utricle is sensing the movements which are forward and backward movements. So it makes sense for the nature to make horizontal macula in the utricle, because if the macula was oblique or vertical, it would not be able to sense that kind of movement. So nature has created everything very carefully. Now, you can also see that in the macula, the hair cells are designed in such a clever way that they face each other at S, which is striatum. And these hair cells are vertical in sacule and horizontal in utricle. Now, these hair cells or this macular lining, what is important about this? Yes, the important thing is that if there is any movement which is towards this long cilia known as kinocilium, then it will stimulate. And if there is any movement which is away from the kinocilia toward the smallest hair cells, then it will inhibit. So if you are stimulating your right horizontal semicircular canal, then the left will be inhibited. So the nature works in such a way that if we want to do one thing which is very important for us, then we need inhibition of the other side. Otherwise, both will be activated, and that's no good for anyone. Now, on the surface of these hair cells, you can see some gelatinous membrane which contains a lot of calcium carbonate crystals. And this is very important because, as you have just seen, that sacule lies in a vertical position, and the macula of the sacule lies in the vertical position, and the macula of the utricle lies in the horizontal position. This allows the inertia. This gives the little weight on the top of the hair cells to remain in position and only move when there is a stimulus. Otherwise, they will be moving here and there with the slightest of any movement which is not required to create the balance stability. So these crystals are very important. But what happens when these crystals fall off? We will discuss this. You can see this supporting cells, hair cells, and otolithic membrane. These are the hair cells. So as I discussed with you, that in the pathophysiology, any stimulus towards big cilia known as kinocilium will stimulate. You can see that in this diagram, the sacule is inactive. The reason sacule is inactive because the person is neither going up nor going down, but the person is going forward or backward. Now, this is the job of utricle. So utricle will become active because the utricle is having a macula in the horizontal plane. So this horizontal macula will either move forward or backward. But what happens when you get a whiplash injury? When you get a whiplash injury, it moves very fast forward and very fast backward. And in doing this, some of the little stones known as calcium carbonate crystals, they can come out. These are the jobs which our sacule and utricles are doing. You can see up and down movement where sacule is doing the job. As long as there is no angular motion, it is the job of the sacule. And if you're going forward and backward without any angular motion, It is the job of the utricle. Now, in the semicircular canal, these canals are responsible for angular motion detection. So you can see that on nature, on one side is looking at the linear motion, which is forward, backward, up and down, whereas on the other side, it is looking at the angular motion. The angular motion can be it can be horizontal, it can be tilted, it can be in any form where there is an angle, except tilt. You can see that in the ampulla, not all openings of the semicircular canals have ampulla. Ampulla is the dilated end of one end of the semicircular canal. In this, there is a sensory lining called cupula, uh, which is a gelatinous mass sitting on the hair cells. Now, this gelatinous mass cupula is sitting on the sensory lining crista. And this crista has got the same kind of hair cells, supporting cells, and again the kinocilium, long cilia and the short cilia. And it depends if our stimulus is towards the long cilia, it will get stimulated. If it is towards the short cilia, it will be inhibited. So if one canal is stimulated on the right side, the counterpart will be inhibited on the other side. And this is how it works. The vestibulo-ocular connections allows the three canal, which are horizontal, posterior, and anterior, to cause excitation of some muscles particularly. But without going into some complexity over here, let me just show you the excitation first of the horizontal canal. Now, you know the horizontal canal is like this, right? So if I am moving my head towards my right side, my lateral rectus is being stimulated over here. My lateral rectus is stimulated over here, and my medial rectus is stimulated over here on the right side. Now, this is how I am focusing on the object which I'm seeing on the left-hand side. So the medial rectus will be excited, but the contralateral medial rectus will be inhibited. So this side will be excited, but this side will be inhibited. And I'm exciting my contralateral lateral rectus, but if I'm moving my eyes, for example, to the right, which is lateral rectus, then I have to inhibit the medial rectus. I can't do this job by exciting both. So if I'm exciting the lateral rectus, I have to inhibit the medial rectus. And if I'm exciting the medial rectus to look on my right, then I have to inhibit the lateral rectus. But without going into more detail, because this is...
I'm sorry to interrupt. The participants are saying they can't see your movements. So if you can turn your camera on, please.
Oh, I'm so sorry.
It's okay.
Can you see me at all? Can you see me?
Hina, we can see him, so they should be able to.
I think camera is on. We can see.
Okay.
Guys, I'm so sorry to every one of you. There must be some technical problem somewhere, which I have to understand.
Thank you. Sorry.
So these are the moments over here. You can see which rotation you are going to, and this stimulates the semicircular canal accordingly. Again, for the primary care physician, this information is not required. Now, we come to the term dizziness. Dizziness is not a precise term. Dizziness is a very imprecise term. Different people will see you, whether you are an audiologist or a clinician, with different history. Some will say a sense of spatial disorientation, motion of the environment, or lightheadedness, or associated with the sensation of instability. Now, but basically, whatever they come to you, whether I'm feeling lightheaded, I'm feeling fainted, I'm feeling room is spinning, or my head is spinning, or I feel instability, you will be able to categorize them into three categories. So vertigo is the one where you get the spinning sensation. We will get the history of a spinning sensation. And then the person will say syncope, which my cardiovascular colleague will be tell you better, but it's a sensation of falling down, feeling lightheaded to fall down. And this is like a vasovagal effect as well. Then we come to non-syncope and non-vertiginous. They will say that I'm floating, I am unable to balance myself, and that kind of sensation. But you will be able to differentiate in many cases, but not all cases, because the history is sometimes very vague, and the person find difficulty to explain because they don't have that kind of they don't see anything like this outside in the outside world, so they can't compare this with something to tell you exactly how they are feeling. Some will feel that my mind is not with me, I feel floated, um, but be ready for all this description. Now, as I said that I'm going to discuss the peripheral problem, so let's stick to peripheral problem. Now, the peripheral problem, now first of all, people talk about vestibular migraine. Let me tell you, vestibular migraine is not a peripheral disorder, and I'm going to discuss this if time permits. The common conditions which we find are benign paroxysmal positional vertigo, which is the commonest of the vestibular problem, but we also find vestibular neuritis, labyrinthitis, and we are going to discuss this. Meniere's disease, now Meniere's is becoming a condition we hardly see unless the old folks come to our clinic. Semicircular canal superior semicircular canal descents. I have seen only 5 or 6 cases in my lifetime, so you can imagine how rare we are talking about. Acoustic neuroma, a clinician will see 1 case every 1 year or 2 years, depending upon your workload. Enlarged vestibular aqueduct, again, it's not common at all. Perilymphatic fistula, not common at all. Vestibular trauma, you can have vestibular trauma with a severe traumatic brain injury. We will discuss this, but it's not something which is seen normally, because severe traumatic brain injury, even if it is moderate, it's not that common. But I'm going to discuss mild, moderate, and severe later on. Cholesteatoma, yes, skin can grow inside the middle ear and can affect the vestibular system. It can erode the bone. It can cause hyperfunction on one side, but not bilateral, depending on the site where the cholesteatoma is. Now, central causes are vestibular migraine or PPPD, persistent perceptual positional dizziness. Central causes, we have to differentiate the peripheral with central sometime. As I discussed with you that sometimes when you get the when a person gets the anterior inferior cerebellar artery infarct, you have to be careful what symptoms the person is complaining of. So cerebrovascular diseases, infarct, TIAs, tumors, multiple sclerosis, Mal-Bartman syndrome, and medications, cardiovascular conditions like rhythm problem or as well. The malingerers are the one who are trying to gain benefit. For example, after road traffic accident, for example, they are complaining of dizziness, but we have to be very careful when we see such patients. So as a medical legal expert, you have to be extremely careful. Hello, can you hear me? Hello?
Yes, we can hear you.
I don't know what happened then.
I think a couple of windows are emerging on your screen, so you can just minimize it.
Yes.
Yeah, we can see them.
Therefore, as we are dealing with a condition which can be due to vision, which can be due to proprioceptive, which can be due to vestibular, which can be due to central cause, which can be due to medication, which can be due to cardiovascular condition, which can be due to psychological, and which can be due to some other conditions which are important like PPPD, which I will discuss is not exactly um, a peripheral or a central disease as such. Okay, the history is very important. When you take the history, you want to know the timing of the uh, dizziness, whether it is acute or chronic. Your patient may come with an acute, they may come to the A&E, or they may come to your clinic with chronic condition. So you want to know whether it's an episode or it's persistent feeling, whether it is for seconds, minutes, or hours, whether the condition is same as it was 3 months ago or it is progressive. And you want to know the triggers because these are important. If it is a positional vertigo, you can have few diagnoses right in your mind, straight in your mind, and you can say, right, I'm dealing with a positional vertigo over here, and you know what common positional vertigos are. So orthostatic, you have taken the history that when they stand up, they get the dizziness, or when they bend, they get the dizziness. Visual, when they are looking at a very high degree of visual information like computer or uh, superstore or some designs on the carpets or crowds, they feel that they are getting dizziness. Valsalva maneuver. So if person is getting dizziness with Valsalva or noise, the diagnosis is coming to your mind with everything, right? And we are going to discuss this. The symptoms are important. As I said that the vestibular system is sitting very close to the cochlea. So many of the conditions can have the hearing loss as well, which may also consist of the cochlear symptom may also consist of fullness of the ear and tinnitus. You also want to make sure that there is no headache because there may be a vestibular migraine or there may be headache due to the central cause. You also want to know whether there is a diplopia, dysphagia, or dysarthria, like a slurred speech, or dysmetria, where the movements are overshooting, or hemisensory problem, or they're complaining there are pins and needles, so they can't feel, or there's a gait or ataxia problem. They are pointing to you towards cerebellum or brainstem problem or the cerebral problem. So be careful when you ask the patient, it's not just the dizziness you are asking the associated symptom, which is going to give you a good clue about the diagnosis.
Sir, I'm sorry to interrupt again, but if you can go in the slideshow, the participants will be able to see it clearly.
Sure.
No
I
problem.
agree.
I think you have a pop-up on your screen, or
Does it
down,
just come and
down
then
right side. Yeah.
Okay, thank you very much. So the examination, I start in this pattern, but you have got the right to start in any way you want to. But naturally, the logic is this, that you want to examine the neck first, make it out first. Make sure that you examine the neck, that there is no cervical spondylosis, the neck movement is okay. The reason is this, that when you are going to do the head impulse test, your neck movement is very important information for you. So then you want to examine the ear, you want to make sure that there is no ear condition over here. Then you go and check the smooth pursuit by asking the person to follow the finger, and then saccades by using your finger on either side to go up and ask the patient to look at the raised finger and to see if there is any corrective saccades over there or not. And nystagmus, Yes, important that you ask for primary gaze nystagmus and 30° to the right and left. The head impulse test is important. You need to really flex a little bit and 20°, and then move the head in a way that it is random, rather than the person knowing what time you are going to do it, because that's no good, and they can stop this um, result of this test. So it's important. Test of skew, you cover the one eye and then you ask the person to look at your finger, and then you open it to look at the vertical strabismus which can be present. And this is an important sign which I will discuss. Romberg test, you ask the person either, some people will say cross the arms on the body, some people will say put the arms on the side. It doesn't make any difference. Whichever you want to do, this is fine. But and ask the person to look at you, open the eyes for 30 seconds and then close the eyes, and then see how good they are to balance themselves. Little bit of minor imbalancement is okay. You know, if they are a little bit shaky or like this, it's okay. But if this is a significant imbalancement, or they tend to fall on one side or backward or forward, whatever, then your Romberg is positive. You can do this Romberg in a patient who has got some gait problem, neurological problem. You ask them to bring the foot in such a way that the heel is touching the toes of the other foot, and see if they are able to do this, because not everyone will be able to walk properly or balance properly. Some will have some other associated condition. Unterberger test, in which you ask the person to the Romberg is not a specific test for the vestibular system. The Romberg test can be positive in the sensory problems and the vestibular problems as well. It can also be positive in the lateral in the lateral spinal tract problem, which can be affected by the cerebellum itself. Unterberger test, if this test is positive, the person will you are asking the person to stand still, march with eyes open, then eyes closed, and count for the 40 steps. And if the person is going more than 45° to one side, then this test is highly suggestive of some vestibular weakness on one side. But what happens when there is a vestibular weakness on both sides? It will be very difficult for them to do this test. But then it's not specific. It becomes very suggestive when the person is moving to one side more than 45°. Supine roll test is a test in which you ask the person to lie down. Now, the lateral semicircular canal, when you look at the person sitting, the semicircular canal is not straight while you are looking at the person. The semicircular canal makes an angle of 30°. So when you are doing the supine roll test, please make sure that you put a pillow, one or two pillow even, before. One pillow is more than enough usually, but sometimes when these pillows are very thin, you want to make sure there are two pillows. So, and then turn the head 90° if possible. Now remember, your patient may have the cervical problem. So you want to do this as much as they can tolerate, and you want to see the nystagmus. If this nystagmus is with a fast phase going up or going down, if the nystagmus happens, then this is suggestive of lateral semicircular canal Bppv. You also want to do the Dix-Hallpike test. In this test, I'll show you. This test has got some diagrams as well, so it will be much better if we look at the diagram. You want to do some cerebellar test, and then you may have some information or some doubts for which you want your colleague audiologist to look at this patient and do some lab test. Now, as I said earlier, that in casualty in A&E, it becomes very difficult whether you are dealing with a peripheral disorder or a central disorder. So when you are doing the head impulse test, if it is abnormal, then it is suggestive of peripheral disorder. Whereas in the central, it will be normal. The head impulse test can also be done by putting cold and hot water, like your caloric. Nystagmus. In the peripheral condition, the nystagmus may not be present, or it will be present in one direction. Whereas in the central, it may be present bidirectional, or it can be vertical, or it can change the direction. The test of skew, when you cover the eye with one hand and then look at the other, and then ask the person to, and then remove the hand to look at the vertical skew. It is present in the central, but not in the peripheral. Now, in the test, the HI&T is hint. HI, head impulse, and nystagmus, and T, test of skew. So when there is an acute vertigo, if you look at the hint test, and at the hint test suggests that there is no nystagmus or unidirectional nystagmus, no vertical skew, but abnormal head impulse test. So you are going to treat this as a vestibular disorder. But if the hint test is negative, then it can still be peripheral disorder like a Bppv. So you will do Dix-Hallpike test. So hint test is not is okay when it is positive for the head impulse test. But when the head impulse test is negative, then you have to do the Dix-Hallpike test to exclude the most important condition, which is Bppv, posterior canal. Now, if the Dix-Hallpike test is negative, then it takes you to the neurological conditions. Then you will be assessing, or your neurologist colleague will be assessing this patient. Now, one of the rare condition, I'll take the rare condition out first of all, which is a perilymphatic fistula. The perilymphatic fistula is an abnormal connection, a tear or defect in one or both membranes over the oval and the round window that separate the airfield. Middle ear. You know that in the middle ear there is air, and there is fluid in the endolymph and perilymph. Endolymph within the sac, and between the bone and the sac is the perilymph. So when I say sac, I mean the membranous labyrinth. So if there is a tear, then this perilymph will flow out and will cause perilymphatic fistula. And this perilymph will flow out more if there is a rapid increase in the intracranial pressure, for example, weightlifting, when there is a raised sneezing and coughing, or if you were to blow your nose, then this perilymph will come out quite significantly at that particular time. The reason why it can come is because of whiplash injury, acoustic trauma, head trauma, descent of an aeroplane, scuba diving. There are many causes, but as I said, the condition is rare, and you don't see this condition as much as it used to be when I was a student. The diagnosis is nystagmus on fistula test is when you do the Valsalva maneuver, you can see this nystagmus. So be ready. If you want to exclude this, you must have that old type of oroscope where there was a little pump to pump the air, or ask the person to close the nostrils and blow the mouth with closed mouth as Valsalva. So whichever method you want to use. The superior semicircular canal dehiscence means a defect in the superior semicircular canal. So in a way, it is also a perilymphatic fistula, isn't it? Because the bone is missing at the top. So the perilymph is in connection with the outside, and normally what is outside the perilymph is the bone. And if there is a bone has got a hole, then it becomes a third window. The two windows are oval window and round window, and this becomes a third window. And this third window, as you can see over here, there are patients whom I have seen very thin bone development, and there are patients very rarely, again, I have seen whether there is no bone at all. And these patients, they get dizziness due to loud noise. The vertigo and oscillopsia can happen due to very loud noise or Valsalva maneuver. So if your patient is saying that as soon as I hear some loud sound or I do some coughing, sneezing, or straining, I get dizziness, then think about this condition. The person may hear their own voice, and there may be some conductive hearing loss on the audiogram. Sorry. If you want to diagnose this condition, then you can do high resolution CT scan, because normal CT scan may not pick this one up, or you can do the vestibular evoked myogenic potential, which our audiologist colleagues perform for us. Now, the bilateral vestibular hypofunction. So we are talking about both sides, which is bilateral. So the condition has to be a general condition. For example, ototoxicity, or it can be an autoimmune disorder. For example, Cogan syndrome, rheumatoid, and a few other conditions which we see normally in rare circumstances. It can be due to some meningitis. At some stage, meningitis can involve both sides, because if you remember, those who are my audiologist colleague, that meningitis has got 8% incidence of hearing loss. So the incidence of the vestibular hyperfunction bilateral is less, but it is present, and in countries where the meningitis is very common, but not in the UK. Again, you have to look at the vestibular test on these patients to look at the hyperfunction. Calorics test will be diagnostic of this condition. The prognosis is not good in the short term, but not bad in the long term with the vestibular physiotherapy. Now we come to the most important point, important subject, which is positional vertigo. Now, when there is a positional vertigo, people always think that could this be a Bppv? But also remember, yes, most of the cases which we see are Bppv, but it can be central positional vertigo. And some cases of vestibular migraine can also give rise to the positional vertigo. Perilymphatic fistula can also do that. Now, positional vertigo, you can get the history like, oh, doctor, when, or audiologist, after lying down or sitting up or turning or rolling over in beds, bending forwards, tying shoelaces, head extension, looking at top shelf. And this is why the Bppv of posterior canal is also known as top shelf syndrome. So shampoo balls in parlor, rinsing hairs in showers. Patient may not be aware of the relationship. You see, not everyone is going to give you a very good history. So be ready to have try to find the link if possible. But as I said to you, that some people may not give you this link because they have not realized there is a link. Though there is a link, but they have not realized. Now, benign paroxysmal positional vertigo is the commonest cause of vertigo or the commonest vestibular disorder as well. The prevalence, it is more common in female, and the incidence increases with the age. So after the age of 50, the incidence increases, but it can be found in the younger age group as well. Up at the age of 80, there is a reported incidence of 10%. Now, if you remember, I was showing you, I did show you some otoconia membrane, otolithic membrane with calcium carbonate crystals. So due to head trauma or due to rapid movement or due to aging, and there are maybe other causes as well, which we are not very clear about it, there is a dislodgement of a little particle of calcium carbonate from, most likely from the utricle. And this lies in the utricle, but it gives rise to symptom when it reaches the semicircular canal, and especially the gravity helps this particle to reach the posterior semicircular canal. Now you can see over here in this diagram, if you look at the utricle and if you look at the saccule over here, if the particle is in the utricle, then it is most likely to fall in this posterior canal where the ampullary end is present. So this is why the 80% of the Bppv cases involve posterior canal due to gravitational reason. One of the important thing which I would like to discuss over here is, sometimes when I discuss with some students, they have got this understanding that the otolith is only in the long arm of the canal, which you can see over here is known as Canal Lithiasis. Now, not many students of mine know this, but this can be within the capula and it can be towards the utricular side of the capula. So it can be the dot which is towards the utricular side is vestibular lithiasis. The dot which are in the capula are capulolithiasis, and the dot which are in the canal are canal lithiasis. But the most common is the canal lithiasis, which we normally see. This, as I said, it's idiopathic. Usually it's unilateral. In the head trauma or whiplash injury, there is a higher incidence. The reason is that the head trauma, the blow or concussion injury or mild, moderate or severe traumatic brain injury can dislodge this otoconia from the utricle. And if you remember, I said to you that utricle macula is responsible for, is inactive when there is a forward and backward movement. And if there is a whiplash injury, then acceleration and deceleration injury can give rise to otoconia, otolithic membrane to go rapidly forward and backward. In this process, it dislodges the otoconia. And sometimes we hear the history of vestibular neuritis or Meniere's disease or dental surgery when there is a lot of drilling going on, the patient is lying down in the dental chair, and there is a history, but we are not sure whether it happens or not. This is what we think. Patients are usually aware of the positional triggers and specific position, so they tend to avoid this position. But because they are bothered too much, they usually contact their GPs. There may be a slight delay because they think that, okay, this might disappear. But when it doesn't disappear, they always contact their GP, who are sometimes very expert in performing the Dix-Hallpike and Epley maneuver, and some who don't have this experience refer this patient to the clinics, their local hospital clinics. Sometimes these episodes are single episodes, and sometimes they are in clusters, one after another. The presentation is a spinning vertigo. Sometimes you can also see that there may be a body tilt. In some patients, they feel that they have to tilt their body. Disequilibrium, they are not very well balanced, occasionally nausea and vomiting. But oscillopsia is not seen in this condition because oscillopsia is a characteristic of the bilateral hypofunction or acute failure of the vestibular system. And because later on there is an adjustment, so in the bilateral also there is a lot of adjustment taking place, whereas this condition is unilateral. So there is, when I see oscillopsia, I think of any other problem associated with this condition rather than Bppv giving rise to oscillopsia. There may be asymptomatic period of months to years. So these patients may say, oh, doctor, I'm feeling a lot better. You know, doctor and audiologist, I'm feeling a lot better. And they learn this technique, you know, they put pillows on one side, they hold their neck stiff, or they tend to lie down slowly. So they adapt. But this adaptation is to avoid the trigger. Now, let's see, look at this canal. As I said to you that if I'm moving on one side, let's say to the right side, the inertia of the endolymph will move towards the left side, and then this will go towards the kinocilium, which is the longest hair cell, and this will stimulate. Whereas on the other side, this same inertia is going towards the smallest hair cells away from the kinocilium. So if I am stimulating one canal, I am inhibiting the other canal. Now, when we look at this plane, which is the Ralph plane, you can see that right anterior and right posterior at 90 degree. But if you look at the right posterior and left anterior, they are counterpart to each other. Similarly, right anterior and left posterior are counterpart to each other, but right horizontal counterpart is left horizontal. So how we can test the right horizontal and left horizontal by supine roll test. Now, if we were to test the right posterior, then we have to make a very oblique position of the head to make it fall down. And even then we will not be accurate. So what we do is we turn the neck 45 degree to one side. When we do this, we find that the right posterior is in the sagittal plane. The sagittal plane is the plane which is nose to the occiput, but because we have, when in the original sitting position looking forward, this posterior canal is making an angle which is 42 to 52 degree angle. But if in this creates a problem for us to do any test on the posterior canal, which is the usual culprit. So what we do is we ask the person to look 45 degree. When we do this 45 degree, now if you were to look at the sagittal plane over here, then you will see that this posterior canal comes in the sagittal plane. So now if you ask the person to, if you drop their head, then really you are stimulating maximally the posterior canal. And that is the idea of 45 degree turn. Now, when we turn this neck and drop the head, then there is an angular acceleration towards the other side, and there is a flow of endolymph, which is stimulating the sensory epithelium of the crista. Remember, in this diagram, you can see that, remember, left and right horizontal canal are at 30 degree. And I'll discuss this with you in a minute. The nystagmus of the posterior canal is upward and torsional. So in this diagram, if you can see that, if you were to test the right ear going down, then the nystagmus fast phase will be upward and towards the ground. Whereas if you were to test, or you can also say that it will be anti-clockwise. And if you were to test the left ear, now just imagine the left ear on the other side, it will be upward and it will be torsional again, because it is going up and turning, up and turn, up and turn. So make sure that you look at this torsional nystagmus, which is vertically, but is towards the nose on the left side and towards the temple on the right side. It's very important to remember this point. Now, diagnosis of posterior canal Bppv, it appears when patient is positioned to the affected side. So if you don't if you were not to put the patient head down on the right side, and if the right ear was not affected, then you will not see nystagmus. So it's only are seen when the right ear is affected and the right ear in the Hall-Pike test is positioned down. There is a torsional vertical nystagmus present. There may also be upbeat nystagmus in uppermost eye, which is the other eye. Now, because if you're putting the head down on the right side, then your left eye is the uppermost eye. This is why I always say that never perform Hall-Pike test by standing behind the patient. Make sure that you are standing in front of the patient. The patient must fixate to the examiner's nose, so it has to be a primary gaze. You will see a nystagmus with a latency of 8 to 12 milliseconds. It comes, stays, and then goes. So the duration of the nystagmus is less than usually 30 seconds, but it can be 40, 50 sometimes. And sometimes you can see a few seconds later, there may be a lesser intensity reverse nystagmus present. So rather than upbeating, it can be downbeating, but only after the position has been changed to the sitting position, not otherwise. So in the position of the Hall-Pike, you will see the upward and torsional, but sometimes when you put this patient in the sitting position, the nystagmus can be reversed. So if you are sitting in front, if you are holding the patient from the front, you can see that a lot better, but not if you are standing behind the patient. And if you do this test a few times, then you will see that there's a fatigability. The response, the reflex disappears. So the best chance is the first or second, but not third, fourth, or fifth. You may not see this. The test is Dix Hall-Pike. Let me see if, yes. Usually we don't use Frenzel glasses. What we do is we turn the neck to the 45 degree. So you see, we don't know which ear is affected. So we have to test each ear. Turn the head 45 degree. Can you see a very important point over here in the bottom diagram, that the head is hanging below the table, level of the table. Now this is very important. I sometimes see patients being tested, their head is not hanging, and that does not give the rolling of the otolith in the canal. So please, if you are doing this test, make sure that you do this test with the head hanging below the level of the couch. Now, if this test is positive, what can you do? You can really treat this patient with possibility of 18% recurrence in year 1 and up to 50% of recurrence in 5 years, particularly in female and elderly people. The higher recurrence rate is more in female and the elderly group. So what you do is, let's say that we have got this patient who has got the right Bppv. So we have put this patient in the diagram, which is over here, second diagram, if I can show you this one. Can you see my arrow, Dr. Hina? Hello?
No, we can't. I can't see the arrow now.
Okay, let's look at the patient who is sitting, and then the arrow, and the patient is down with the head tilted and hanging below the table. Now, if this is the typical Dix Hall-Pike maneuver, let's say the test is positive, you have seen the vertical torsional nystagmus. So what you do is you tilt the head from the right to the center and then to the left. Do this very slowly. So from right 45 degree, the head will go straight, looking to the ceiling, and then towards the left as looking towards the left side of the wall or ceiling. And then you turn the head in such a way, but very slowly, that the head is looking at the ground. When the head is looking at the ground, wait for 30 seconds to a minute and bring this patient to make this patient sit. Now, again, you can see the person is standing behind on the right side, whereas on the left side diagram, the person is standing in front. So the person on the right side is doing it wrongly, whereas on the person on the left side, which is the white colored diagram, the person is doing right. So you bring the patient head tilted towards the shoulder and make them sit. After 10 seconds, you make them make the head straight. Now there is a lot of controversy. What should be done after this test? Shall we ask them to lie down on pillows or for hours and not to do anything? There are different people who do different ways. This is what they have devised and they have learned from their own experience. So I'm not saying one method is right or wrong, but there's no clear statistical evidence that those patients who took precaution of lying in the pillow in the semi-reclining position were better than those who didn't lie in the semi-reclining position. And this is what the literature says. Now, this is not the only test, which we can use. There are other tests also, which can be done. For example, Simone Test. In the Simone Test, what we do is, for example, the person is suffering with the right benign paroxysmal positional vertigo. You ask the person to sit as they are facing you, and you turn the head towards the left side, towards the unaffected side, and then put the head down. In the same posture, the left is tilted toward, the head is tilted towards the left side. Person has having right Bppv, you turn the left towards the left side. Then in this same position, tilted left, you make them down. Once you have done this, you have to wait for 30 seconds to a minute. Then you make them sit straight, and then put them back on the other side. Now, after doing this, you have to wait for 1 to 10 minutes. If you read the literature, they will tell you wait for 1 minute, wait for 2 minutes, wait for 3 minutes, 5 minutes, 10 minutes. I practice only 2 minutes, which is more than enough for my patients. And I don't get much recurrences anyway. My recurrence rate would be 10% or at the most 15% in the first year. If I do 2 or 3, then it falls below 10%. But the overall 5 years recurrence is not affected. If you are most welcome to keep this presentation, or you can look on the YouTube for Christopher Chang Epley maneuver. He has performed this very nicely, which you should copy as well. The recurrence rate, I said to you, there are different groups who have described from 18% to 22% in 12 months and 50% in 5 years. But remember that 5% of the patient can be worse actually. So it's not that your patient is going to benefit. Some may get worse. Some patient may come back to you and say, doctor, I'm feeling worse after this Epley maneuver. So be prepared. Inform them that yes, 5% can get worse. The other reason is that some patients may find that their posterior canal Bppv has become lateral canal Bppv. Now the otoconia can go to, instead of utricle, it can go to the lateral canal. So this can also happen. The factors affecting repositioning maneuver. First is if you perform and you don't find nystagmus, you have done a good job for the time being. The time will tell about the recurrence. Some people use vibration of the skull while doing the Epley maneuver. The literature does not find any great benefit, though some studies have suggested that using a vibration on the skull helps. Now, post-maneuver instruction, as I said to you, there is no clear difference between those instructions which were followed and not followed. Some people I have not seen any case where I have referred any patient to surgery, but yes, neurectomy can be done. If you remember, I especially pointed to inferior vestibular nerve, which was taking the impulses from the posterior canal and the Skew. So this posterior canal information from the inferior vestibular nerve um, can be handled by neurectomy. Also, posterior semicircular canal occlusion has been described, but I just wonder how many patients have been referred and where, not in UK at least, you know. Now, the exercise which we usually ask the patient to perform is a brand of exercises, which you can see over here, which are very simple and straightforward exercises. Sitting, these are the exposure exercise. What we are trying to do is we are trying to ask the person to keep looking up at an angle of 45 degree, lie down on one side, wait, lie down on the right side, wait, do this few times, and you might feel better. They may get the dizziness, but then the adaptation process will come. With the adaptation process, they will feel better. The horizontal canal Bppv, it's a supine rule test in which we put one thin or two thin or one good size pillow, and then you turn the neck to the right and left up to 90 degree. But if you remember, I said to you that make sure that you have done the neck examination to understand the limit of your patient's neck movement. It happens, it constitutes about 20% of Bppv, and there is no or very minimal latency. It starts quickly. So be careful. Your eyes are on the patient eyes to make sure that you pick up this one, but it can last a bit longer than the posterior canal, up to 1 minute. The reason why you are putting one too thin and one big pillow is because if you look at the plane of your lateral canal, it's 30 degree. So forward flexion, if you flex the head 30 degree, then you have brought the patient's lateral canal in line. So this is why the pillow. And some people can hold the head and they can turn the neck without pillow, which is fine as long as you can do it with some flexion. The horizontal canal lithiasis, it's a brief attack of vertigo, less than 60 seconds, provoked by turning in bed. So the patient normally will give the history that when I roll over in bed, I get this dizziness. But not everyone is going to tell you the same with horizontal canal. Symptoms will last days to a few weeks. The stronger nystagmus phase is on the symptomatic side. On unaffected side, nystagmus reversal is pronounced. So if you see the nystagmus on the right side stronger, then the right ear is affected. But we will discuss the geotropic and ageotropic as well. Whereas on the left side, if you are making the patient in the straight position, then you might see a nystagmus on the left side as well. Or you may see the nystagmus while you are checking the nystagmus on the right side. The autoponia in the cupula. So when it is in the cupula, the attack is longer. It's more than 3 minutes. It can be, symptoms can last from days to weeks. There may be nystagmus on both sides, but away from the ground. So in the normal canal lithiasis, horizontal, the nystagmus is towards the ground. But when it is away from the ground, then the cause of this is otolith in the cupula or towards the utricle. If you remember, I showed you the dots. These dots were towards the between the utricle and the cupula, which is called vestibular lithiasis, and within the cupula, which is cupulolithiasis, and within the canal, which is canal lithiasis. So if there is nystagmus which is away from the ground towards the ceiling, upward, then it is highly suggestive of cupular lithiasis or vestibular lithiasis. But these are complicated things. For your sake, I would just say that for the primary care physician, manage your test as a supine roll, 90-degree right or left or whatever degree you can achieve, and look at the nystagmus, whether the fast phase is towards the ground or towards the ceiling. You can see over here the ageotropic and geotropic. The apogeotropic nystagmus is upward, whereas geotropic nystagmus is downward. So most of the time you will see a geotropic nystagmus, which is towards the ground. This diagram will always remind you, if you have got a little notebook, you can put this in your notebook, and I'm sure that whenever you see a patient of dizziness and you're performing the supine roll, you will remember this. So the posterior canal, the lateral canal, geotropic, and the lateral semicircular canal, apogeotropic. So the posterior semicircular canal test is a Hall-Pike test. The maneuver which we perform is Epley maneuver or Simone maneuver, which I've described to you. In the lateral semicircular canal, it's a supine roll examination for both parts of the lateral semicircular canal, whether it's a head down or head up position. Means the nystagmus is towards the ground or nystagmus is towards the ceiling. Then you will perform the Gaffuni maneuver as well according to this test. Sometimes we can also perform the barbecue rotation test, barbecue rotation treatment for a horizontal canal. What we do is we ask the person to lie down supine. Now, there are some authors who would suggest that, for example, if the problem is on the left side, right side, turn the head to the right first, and then turn the head to the left, and then roll over the patient so that they are looking down, and then they turn over the patient as they are looking towards the left side, towards their right side. Now that becomes 360 degree actually. So the original description of barbecue rotation is 270 degree. In 270 degree, the diagram 1 is fine. The diagram 2 is okay, it's turning to the left. Diagram 3 is okay, it's 180 degree. And then the diagram 4 is okay because it constitutes 270 degree. So you don't need to move the head to the right first and then you need to move to the left. But some authors have described moving right and then left. This is enough for you if you are performing barbecue rotation. Now, as I said, if the right semicircular canal is affected, you lie down, make them lie down, roll to the left, 90 degree, roll on to lie down on tummy, 90 degree, and roll to the right, 90 degree. So 3 times 90 is 270 degree. And then make them sit up. You can also perform the Gaffuni maneuver over here. And the Gaffuni maneuver can be done for geotropic or ageotropic. And in the geotropic, what we do is we make the patient as they are sitting in the sitting position and take them to the side lying portion of the unaffected side. So if the person is suffering with right side semicircular canal, lateral semicircular canal problem, then you turn the head to the left side, make them lie down on the left side, and then make them sit and make them lie down on the right side. And if the person is having apogeotropic, then you put the head toward the affected side. So remember that if you have got a geotropic, then the unaffected side goes first. Whereas if you have got a apogeotropic, then the affected sides go first. So this is a little bit difference over here. Just need little reading over here. Anterior canal, I've never seen any anterior canal Bppv, though it has been described as downbeating nystagmus with torsional component. So you can imagine that in 22 years service as a neuro-otologist, neuro-otology, I have not seen any patient with anterior canal Bppv. So this explains how rare it is. The reason why we don't see is because you can see that anterior canal Bppv, even if you were to diagnose this downbeating nystagmus, which will need a lot of investigation to make sure it's not central core nystagmus. But if you were to diagnose anterior canal Bppv, then the anterior canal otoconia will fall down back in the utricle and will go to the posterior canal. And this is what happens sometimes, that lateral canal, which is 20%, if you treat the lateral canal, they may come back to you with posterior canal. Or if you treat the posterior canal, they may come back to you with the horizontal canal. But anterior canal downbeating is extremely rare. There are other positional vertigos apart from the Bppv. So you have to be very careful with the downbeating nystagmus. If you remember, I said to you that if there is a downbeating nystagmus, it's usually a brainstem and cerebellar sign, so be careful. But you can also get alcohol-induced positional vertigo, perilymphatic fistula, head extension vertigo, amiodarone toxicity, macroglobulinemia, which are very rare things to see. This was about the Bppv. I see a question, Dr. Hina. Shall I answer now, or shall I? There is something. Is there any strong association with psychological effects in MDDS? I will come to MDDS at the end. Thank you. I've seen your question. In your experience, which one is superior, or beta histidine, or I'll answer those two questions in a minute. Yes.
Okay.
Okay. The labyrinthitis. There is a difference between labyrinthitis and vestibular neuronitis. The labyrinthitis is the inflammation of the inner ear. So the patient may come to you with spinning sensation or non-spinning dizziness. They may say that it's difficult to balance. There may be occasionally there may be nausea, but not vomiting usually, unless it's a very acute labyrinthitis in the first 2-3 days. They may have. They may be suffering with tinnitus, or they may be having hearing loss, high frequency. All these symptoms may not be present in one patient. So the typical full-blown picture is the one which I'm presenting to you, but your patient may just come to you with acute dizziness, with some nausea or maybe vomiting. Now, this condition is caused by respiratory viruses, herpes, and Lyme disease, sorry. The risk factors are those who drink too much, or those who smoke too much, or there is a stress or fatigue or allergies. They are the one who are more likely to get this. So usually it disappears on its own with the help of some medication prescribed in the acute phase. A patient lie in quite dark room with plenty of water to drink, and they are not allowed to drive and drink alcohol. The question was about which medicine is good. You know, cinnarizine is calcium channel blocker as well, so be careful about it. But otherwise, you can give cinnarizine to any patient with no heart problem. Stemetil is fine. There is no problem with the stemetil. Most of our GPs prescribe stemetil over here. One thing we must remember that these patients should have early mobilization. You don't want them to lie down in the house for days and days and days, because that takes away the rehabilitation, that takes away the improvement. As soon as they are feeling better, they are going to the washroom, they can come out of their room to the other room, and then they should start walking inside the house with support and without support. So the condition usually disappears on its own. But sometimes, in very rare cases, it can give rise to Bppv. And there are patients who suffer with PPPD. They also give history of labyrinthitis. Now, vestibular neuronitis is an inflammation of the nerve of the vestibular system, The symptoms are going to be the same as labyrinthitis, except the tinnitus and the hearing loss will not be present, because the labyrinthitis involves the inflammation which goes through the canal. Even if it is affecting the labyrinth, there is a duct between the saccule and the cochlea. The inflammation can travel through that part, through that endolymph. So in vestibular neuronitis, you don't get this tinnitus and hearing loss. It can be viral. The nystagmus can be fine, horizontal, and fast phase away from the affected ear. So if you were to see this nystagmus, in some cases, this will be away from the affected ear, and it beats in the same direction even if the head is rotated, which is very typical of vestibular neuronitis. It is reduced with fixation, so with which most peripherals are reduced. Acoustic neuroma is a growing condition. It now depends upon where do you count this as a peripheral and where do you count this as a central. If it is happening within the IAM, internal auditory meatus, it is a peripheral disorder, which will give rise to the asymmetrical hearing loss. Disequilibrium, if the vestibular nerve is affected, there may be a caloric high function, so neuroimaging is required. So the patient may come to you with unilateral hearing loss or unilateral tinnitus with dizziness, with or without dizziness. Ototoxicity, as I have discussed earlier, that ototoxicity can give rise to bilateral vestibular hyperfunction, and aminoglycosides such as gentamicin and cisplatin, especially cisplatin, is very well known to cause vestibular hyperfunction. Streptomycin was once a very common cause, but these are also the other medicines which are known. Meniere's disease, it's a peripheral disorder. It's of the endolymph. So the understanding is this, that there is an inability of the endolymphatic sac to absorb excessive fluid which is being formed. And so there is an overproduction which is difficult to get rid of. Maybe there is an obstruction of endolymphatic duct. So there's a history of tinnitus, fluctuating hearing loss, and dizziness. So this triad of symptom is present, associated with nausea. And the situation is that in the Meniere's disease, initially there is no hearing loss, but then there is a low frequency hearing loss, which becomes flat, and then it becomes high frequency hearing loss. So if you get a patient who are suffering with tinnitus, dizziness, and hearing loss, which is fluctuating and lasts for hours, then your patient is likely to be suffering with Meniere's disease. You have to be careful with their management. They should they can have low-salt diet, diuretics, vestibular suppressant, bromate in some cases, intratympanic gentamicin in very, very few cases. Surgery, it's becoming rare now. We used to see, but not anymore. The vestibular migraine, it's not a vestibular pathology. It's a pathology of processing, where there is a processing problem in the central pathway with the sudden onset of vertigo. Headache may be present, may not be present. So even if the headache is not present with dizziness, but there is a history of vertigo where the headache has been present before or may not be associated at that time or may come later on, then there is still a possibility of vestibular migraine in these cases. There will be a photophobia, but vestibular tests are normal. This was the question about mal-debarkment. It is very rare and poorly understood. It's a phantom perception of self-motion. It is described as rocking or swaying, uneven ground below their feet while walking, feeling as if they are still on a boat, persistent dizziness for hours, weeks, months after an ocean cruise, a sailing trip, a prolonged air flight, a cross-country road trip is highly suggestive of MDD. It's exacerbated when patient is not moving. Now, see, it's not like a positional. So when the patient is not moving, it becomes more pronounced, sleeping or standing still. Also when exposed to fast movements, for example, in rides, flickering lights in the city centers, with the lights going on, and grocery store aisles. The triggers, as I said, ocean cruising, sailing trip, prolonged airplane travel, sleeping on waterbed, they are known to cause this. There is inadequately processing and adaptation to multiple sensory stimuli. So it's a processing problem rather than any pathology happening. And this is why the vestibular function tests are normal. Clonazepam at low doses, once or twice a day is given. The patient feels usually better. Now, this is a condition which is persistent. I think there was a question by Dr. Abdul Hafiz. Abdul Hafiz, you wanted to ask me about this condition. Is that right? Dr. Hafiz?
Yes, Dr.
Because you have seen many patients like this, right? Is that what you said to me?
Yes.
Right. So persistent perceptual positional dizziness is a maladaptation. Sorry for spelling mistake over here. To vestibular disorder and processing problem. Now, there is a very well-known trigger over here. These patients will give you a very clear history that then when they see visual trigger, like lights or carpet designs or crowds or rides or something going round and round, computer, and when there is a head movement, they feel this constant fluctuating dizziness. If we examine this patient, we find that the tests are normal. We usually refer them for CBT and vestibular physiotherapy. This is different from the psychological dizziness. In the psychological dizziness, the triggers are not present. The psychological case history will be slightly different because of the triggers. And the psychological patient will not tell us about the fluctuating dizziness. They will tell us about the constant dizziness, usually, but the history can be different in some cases. So I think this is what I have to present. So shall I just switch it? Right. Any questions?
Yeah, thank you for an in-depth presentation covering lots of topics, including the basic anatomy, histology, the pathways, and the clinical conditions. I think some of the questions have been answered in the chat box. There was a question in the Q&A, sorry, most of them have been answered in the Q&A box. There were some in the chat box. One was, can we do Dix-Hallpike Epley's maneuver in patients with cervical degenerative disease? I don't know if you would like to answer that or one of the panelists.
Sure. You see, as I explained to you that the posterior semicircular canal to be in the sagittal plane has to be, it will be when the head is turned 45 degrees. Now, if your patient is unable to move the neck beyond 30 degrees, then yes, you will find problem. But if your patient is able to move neck 30 degrees or more, then you will be able to perform the test with ease. And if they are able to move 45 degrees, then it makes it very easy for any examiner to perform this. But
Okay,
make sure that you are in front, you're not behind. Yes.
Okay, great. Thank you. Can I just ask the panelists to introduce themselves to the participants? I know we've got 30 participants down. We were up to 91 and we've got 65 now. So if we can just quickly introduce ourselves. Dr. Noreen, if you can introduce yourself, please.
Assalamu alaikum. I am Dr. Noreen Rafiq. I am a graduate of King Edward. Did my residency at Creighton University Medical Center in family medicine, and I'm currently here as associate professor and core faculty.
Amjad, if you can.
Thank you for the.
My name is Assalamu alaikum. My name is Dr. Syed Amjad Iqbal. I'm a graduate of Dow Medical College 2003. I've done my core medical training and MRCP in London, and then I moved on to general practice in 2010. And my special interest area is end-of-life care, and I'm doing a master's degree in that as well.
Go next, please.
I'm Dr. Azul Haq. I'm a Khyber Medical graduate, and I did my neurology training from Northwest Deanery, UK. I still remember Dr. Iqbal came to teach us about the neuro-otology on one of our teaching days. And I can't forget when he said on that day that the neuro-otologist is a rare breed in UK because there was problem with the funding issue. I don't know if Dr. Iqbal can remember that or not, but I still remember, like, you know, as it happened yesterday. So very nice to hear you, sir. Thanks for such an elaborate talk. Thank you.
Dr. Abdul Hafiz, can you introduce yourself, please?
Assalamu alaikum, everyone. Dr. Abdul Hafiz, I graduated from Aga Khan University. I've been in UK now for last 22 years. That tells you about my gray hair, my face. I'm a GP by profession. Obviously, Dr. Iqbal is kind of my neighbor, and obviously I benefit from his vast experiences in different domains.
Great, thank you. I got a bit disconnected now. I've lost the Q&A sections, but I'm assuming most of them have been answered. I can't see any unanswered questions in the Q&A box. There was one question in the chat box. Does Epley maneuver trigger severe vertigo? So what advice is given afterwards? I'll leave it open to any of the panelists who wish to answer this question. Any advice afterwards if the Epley maneuver generates severe vertigo?
I think this is a bit complex question for family physicians to answer. However, obviously, we just treat it, you know, symptomatically. Just as a first advice will be just to take some rest. You know, some antihistamine might be of benefit. Obviously, if the symptoms do not get better, then we will get the specialist involved.
Okay. Any of the specialists want to add anything? Dr. Ayaz, is there any other advice you give to a patient in case she's driving home?
Exactly. As Dr. Iqbal very clearly mentioned in his talk that about 80% of the Bppv is due to posterior semicircular canals. So what happens is that when the patients come to see you, ideally you should ask them, you know, like how they've come to the clinic. Are they accompanied by someone, or who is going to drive? One of the reasons is that basically these otoliths, they can sort of dislodge into the lateral semicircular canals, and rather than getting any better, the symptoms can get worse. Apart from that, again, I will give reference of Dr. Iqbal that different people give different advices, but what we learned over the years was that basically when you do the Epley's maneuver, you should also, or we used to tell the patient that, you know, like they should keep at least 2 or 3 pillows when they are going to bed, and drink plenty of fluids. If the patients ring you or the secretary that they have gone worse, the most important thing is that, you know, we need to reassess them. Reassess that whether or not that dislodgement has gone wrong, meaning to the lateral semicircular canals, because then at that time they will need a different sort of procedure for the lateral semicircular canal. Dr. Iqbal will have a final say about that, and that will be.
No, I think you said very nicely and absolutely right, actually. Now, what I do in my practice, I make sure that they do come with someone to my clinic, and they are being driven by the other person. They are not going to drive. For example, if the other person is unable to drive the car, that's no good. So one thing. Second is this, that we want to make sure that there is a sink near around. If they feel nausea, if they feel like vomiting, then they can use that sink or a bowl, whatever is available. The nurse is there. After the maneuver, before the maneuver, I tell them that there's a 5% possibility of getting it worse. And I also tell them about the recurrence rate. So there's a good chance that they will be cured, but there is a small chance that they may not be cured. And they may need a second maneuver, or they may need a repeated home help maneuvers, which I can teach them how to do at home. Now, I don't see them after the maneuver has been done unless there is a recurrence. So it all depends upon person to person, doctor to doctor, what's their practice like. But my practice is very busy, extremely busy, so I don't see them. Patient have to wait 6 months to see me, so I try to reduce this load by passing over the information to GP and contact me when they wish to see me again. And I think it's important that they should learn home Epley maneuver procedure, which can be taught to them by vestibular physiotherapists at home. So, Dr. Yaz, everything you said was absolutely perfect.
Okay, there's another question. In your experience, which is superior or recommended, Stemetil or beta-histine for benign positional vertigo? Anyone from the panelists can answer this question.
So again, personally, I don't know whether there is any specific drug which is like evidence-based for the Bppv or the acute vertigo. But what I tend to do is if the patient has already used one of the drugs, like for example, beta-histine in 8 milligram TDS, what I try to do is sort of, like increase the dosage of the same drug. But if they're using it in a reasonable dose, then I switch the medication. The most important thing is basically the, as Dr. Iqbal was mentioning, is that trying to sort of convince them not to use a lot of these vestibular sedatives, because that has a very negative effect on the vestibular rehabilitation. But on our side, the patients and their relatives, they do like to have some medication. So, like that talking therapy, trying to tell them that what exactly has happened, basically half of the treatment is, like explaining that what the disease is. Yes, we are going to change the medication, but telling them about the Coxycoton exercises, or the simple sort of vestibular rehab exercises which they can do at home, I found that extremely helpful.
Great, and I do realize it's been over. Yeah.
Sorry, if I can just quickly add, if we have to, primary care point of view, if we have to start something, we generally start with Stemetil as a first line. Beta-histine, usually, obviously, we do in our clinical practice here.
Can I say something over here, Dr. Inam?
Yes, please. Yeah.
To be very honest with you, there is no role of medication in chronic dizziness. So patient will be hooked to this medication, will become addicted to all these stomatals and all these things in chronic dizziness. And there is no role of medicine. Yes, in acute dizziness, when the patient is restricted to perform a simple task even, then yes, one can make a case of stomatal. Beta histidine, I don't prescribe beta histidine. Now, beta histidine is for the blood flow. I need to know where is the problem with the blood flow. If there is a problem with the blood flow, then it's not peripheral disorder. It's a central disorder. It's a vertebrovascular insufficiency we are talking about. You can't have a dizziness of a peripheral disorder just by reduced blood flow to the anterior inferior cerebellar artery, which is coming from a system which has a loop system. It's coming, blood flow is coming from below, blood flow is coming from the top. So blood flow is coming from both sides. So this vertebrovascular insufficiency should be handled, this diagnosis should be handled with great care, and it should not be, it should only be by a neurologist or a cardiovascular cardiologist who have done this. But I don't usually prescribe beta histidine at all.
Okay, right. Dr. Amjad, you wanted to say something.
Yes, I wanted to add something as a GP here. So first of all, thank you, Dr. Iqbal. You already stepped in and you answered my major question here. As a GP, you normally get to deal with labyrinthitis and vestibular neuronitis usually. People who have been discharged from Epley's clinic as well, they are given Buckestem, which is a fast-acting buccal 3 milligrams prochlorperazine. That's what is prescribed. As a GP, I've never started anybody on beta histidine for the same reason. There's just a blood flow. It's a vasodilator. Its role is very specialized, and the only few people in my cohort of patients who are on beta histidine are patients who have been discharged from neurology clinic or they've got ongoing support from the ENT department. For GPs, it's prochlorperazine all the way. And again, minimize the use of drugs as much as possible because they have plenty of side effects. They're good for travel use and things like that. But when you're talking about acute ENT disorders, our options are quite limited. And if I can ask Dr. Iqbal, Cinnarizine, is that any good at all? Stuitron, which comes as a brand.
Yes, Cinnarizine is antihistamine, but it has got a calcium channel blocker. So if you just be careful to whom you prescribe, you're fine.
Thank you for that.
Okay, and it's again a related question. I'll just take these last two questions. I know I fully realize it's been over the time that we've been allocated. Any contraindications to the use of beta histidine or stomatal in benign positional vertigo or acute dizziness? Anyone can have a go at it. It's an open question.
Okay, I will answer. As there is no role of medicine in Bppv, unless patient has become worse. Once you have treated them, they are finding restricted movements. They are unable to even go to the washroom or stand up properly and feeling extremely dizzy. You see, Bppv, in Bppv, you get episodes of seconds. So it has to be clusters of episodes, first of all. If the patient is getting clusters of episodes, which these episodes are making patient nauseous, vomiting, and they are unable to do anything. Yes, there is a role of these medicines at that stage. But once they are feeling better, it should be stopped, maybe 2-3 days at the most.
And the last question, what's the pharmacological management of psychological vertigo? People from GP land, if they want to answer this question, the psychological vertigo dizziness, what's the management pharmacological for that?
I think we tend not to go into any pharmacological side. I think this is a condition which we have to, first of all, it's difficult to identify because we tend to, obviously, first of all, when a patient presents with vertigo or dizzy symptoms, obviously it's a thorough assessment. The first question which comes to our mind is it coming from heart? Is it actually dizziness, or is it related to ears? And when it comes to ears, do we need to think about an ENT specialist or a neurological specialist? So when everything has been excluded, there have been cases where we refer the patient, from one post to the second to the third, and then patient come back to us, and all specialists are saying we have completed all the investigations and nothing is showing anything. So these are the kind of patients where we, think about psychological support, and we refer counseling and so on.
I
Great.
would probably
Yes.
just second that. Psychological vertigo is probably a very, very vague term. And CBT would be the cognitive brain therapy would probably be the answer to the question. I have used medications to help, but that's extremely acute conditions. Patient is leaving town and cannot get to physical therapy for Epley's or anything else. All right, you're out for 2 days, take this medicine, come back and we'll take care of you. Yeah, no medications and mostly physical therapy and cognitive pain in case of psychological.
Okay, I think we'll have to call it a day. It's almost midnight in Pakistan and we have to wake up as well.
When you see your patient, please remember to take their blood pressure, lying down, sitting, standing 1 minute, and standing 3 minutes. If the blood pressure is dropping by 20 millimeters systolic or 10 millimeter diastolic in this process, either on standing 1 minute or 3 minutes, then please refer these patients either to geriatrician or to the cardiologist if you have diagnosed orthostatic postural hypotension. So this is one of the examinations you must never forget when you see a dizzy patient. Thank you.
Thank you very much to all the panelists, and special thanks to Dr. Mohammed Iqbal and all the 52 participants who are still with us. Thank you all, and I hope you've learned something today at the end of the 2 hours. Great. Thank you.
Thank you.
And
Bye-bye.
love.